I'm sort of surprised nobody mentioned daratumumab with bortezomib earlier. That hasn't even been brought up as an option in a lenalidomide refractory patient. So Nuper, I'll pick on you again. Why not use that?
You know, part of the reason for not using that is most of our patients have been exposed to bortezomib already up front. The issues around toxicity of bortezomib long-term use is something we've talked about, the neuropathy specifically. And if you look at the old data with bortezomib, daratumumab, although it was a positive trial, you know, the data was not that impressive. The Candor and the IKEMA study, the data looks much better. We tend to use carfilzomib at the time of relapse now. That might change with more people using KRD upfront, but at least for right now, this go-to proteasome inhibitor seems to be carfilzomib at the time of first relapse.
Now, many of you mentioned using pomalidomide. Tom, why not just use lenalidomide again? I mean, I guess I gave the case where somebody was progressing on it, so I made it easier. If they've had lenalidomide and stopped it, would you use pom at relapse, or would you go back and use lenalidomide again?
I think if there's been a significant break, like a 6 to 12 month break, and they're truly not refractory to lenalidomide, I think it's acceptable actually to give that a try, as long as they didn't have toxicity to the lenalidomide. I actually think pomalidomide is tolerated a little better than lenalidomide myself. And so I actually prefer it when they do have relapse. I tend to do that even if they've been off len for a while.
It's been my experience that there may be a little bit more neutropenia where, I don't know if it's comparing to lenalidomide, but when you use pom with dara, for example, that can be a bit of a challenge. Yeah. Anybody else want to?
Yeah, I think that first, I would agree with what Tom says. I think a lot of people who are on long-term lenalidomide really hate the GI side effects that they have, you know, chronic sort of surprise diarrhea, things like that. And pomalidomide really doesn't seem to have that. And I think a lot of patients really appreciate that. So I think that's one reason. But what I will do is if I've had a patient who's had a long-term, say, response on len maintenance after a transplant, then has actually stopped maintenance and then starts to have a biochemical relapse, those are people that I actually will give len again to.
I think, I'm just going to add to that, Keith. Most of us would want to use the most active drugs. So Pomalyst is certainly more active than lenalidomide, and now we have the new cell mods. The worry used to be, what are you going to do next? Well, we do have really active cell mods coming down the pike, so I would go to pomalidomide.
And just for the audience, again, a cell mod is kind of a third generation version of thalidomide, lenalidomide, pomalidomide, with maybe some slightly different biological effects. But there are some very potent ones out there in clinical trials showing iberdomide being the one that we've heard the most about, showing some activity even in people who have failed pomalidomide. So pomalidomide sounds like a good choice. What else have you combined it with, Natalie?
Well, we use some, based on the Optimism trial, we use some Velcade. Actually, I know you mentioned that people aren't using Velcade. We will give POM with Velcade. Typically, in a person obviously who hasn't had previous neuropathy. We actually, one of the regimens that we've used in older people, and I don't know if other people have done this, is an old Palumbo regimen, which is pomalidomide with oral cyclophosphamide and prednisone, which is a triplet regimen you can give older patients and is very well tolerated.
I think one of you mentioned using elotuzumab with pomalidomide. Was that you, Peter?
That was Tom, actually, but I think that the data with elotuzumab PomDex are quite good. I mean, there's a clear difference in overall response and a very significant difference in median progression-free survival with the addition of the elotuzumab. And as Tom alluded to before, the toxicity profile of elotuzumab is actually quite favorable. I think that the challenge with Elo PomDex, is that it's unclear, what its activity is and what its role is going to be in a post-CD38 antibody world, which is where most of us are using it. And just anecdotally at this point, my experience with Elo PomDex in DARA refractory patients has been suboptimal.
So I think we've sort of concluded that POM can be combined with a number of different drugs. It seems to be the IMiD of choice at relapse amongst the group, and that it's pretty active and certainly a good choice in this situation.